Okay, guys, we're going live. Good afternoon. Welcome to the YWCA's Talk on Health. The Talk on Health is a collaborative conversation with the YWCA of Lower Cape Fear and the Wilmington Alumni Chapter of Delta Sigma Theta Incorporated. This conversation and program was created to reach people in underserved communities who don't always have access to healthcare professionals. We hope that you will ask questions in the chat and that you will learn a lot about type 2 diabetes from our discussion today. We have some wonderful panelists and I will allow them to introduce themselves in a few minutes. As always, though, I will start out with the land acknowledgement from the YWCA. The YWCA of Lower Cape Fear serves the people located within the Lower Cape Fear region. This land once thrived with life from indigenous peoples, known today as the Cape Fear Indians and the Waccamaw Siouan Indian people, living in established settlements along the Cape Fear River and Lake Waccamaw, along with many other established sites in the region. We need to protect and honor these places. Indigenous peoples are not relics of the past. They are still here, continuing to demonstrate their talents and gifts amidst a backdrop of ongoing colonialism and oppression. They are worth celebrating. We hope that our land acknowledgement statement will inspire others to stand with us in solidarity with Native nations. Thank you very much. As I stated earlier, well, I didn't introduce myself. I'm Dr. Lakeisha Jarrett, and I'm a family medicine physician with Wilmington Health. I really enjoy doing these conversations every month. Today we have Dr. Parker, who also works for Wilmington Health, and he is an endocrinologist. I'm going to allow him to introduce himself, tell us a little bit more about himself.
Well, thank you, Dr. Jarrett. And I've been in practice in Wilmington since 2003 with endocrinology and at Wilmington Health currently. I've got an interest in diabetes type 1 and type 2, as well as a variety of other endocrine conditions, and I'm involved with clinical research for newer treatments and monitoring modalities in diabetes.
Thank you very much. Next, we have Joshua Jones, who is a clinical pharmacist. Could you please introduce yourself today, Joshua?
Absolutely. I'm Josh Jones. I'm one of the clinical pharmacists that works for Navant Health Primary Care. I work in the clinic setting and work with patients with their chronic diseases, a lot of the time dealing with diabetes, hypertension, hyperlipidemia, and using medications to help manage those disease states. I've been working for originally New Hanover Regional Medical Center, now Navant Health, since 2016, and have been in the clinic setting for the past year.
Thank you for joining us. And next we have Kevin Miller, who is a registered and licensed dietitian. Could you please introduce yourself, Kevin?
Yeah, thanks for joining us today. I am, as Dr. Jarrett said, a licensed and registered dietitian. Have been so for a little over 8 years. I've worked inpatient and out, and actually even worked for an endocrinology practice in Atlanta, Georgia for quite a while. Definitely enjoy working with diabetes because it is a disease state in which managing our diet and our lifestyle can have a huge impact in terms of outcomes. Currently, I work with Summerfield Custom Wellness. We have sites in Wilmington, Raleigh, and also can see people online. And I certainly, like I say, hope to have a great discussion with everyone today.
Thank you very much. So last week or last month, I apologize, we talked about type 1 diabetes. So we are going to just transition from that a little bit by starting out with talking about what the difference is between type 1 and type 2 diabetes. Dr. Parker, could you please speak to that?
Oh, definitely. And again, thanks for having me. And I want to especially thank Velva Jenkins for all the great work she does. So the difference between type 1 and type 2 diabetes gets at insulin, basically. And so we can kind of think about it in terms of the mismatch between with insulin effect. So whether in type 1 diabetes, you have insufficient insulin production. And just to remind everybody, the insulin is required to take the glucose that's in the bloodstream and send it into cells to use it for fuel. So this is just a necessary process. It touches about every inch of our body. But if we don't have enough insulin, that's generally characterized in type 1. There are some fine points about that with type 2, but basically there's an insulin deficiency. In type 2 diabetes, we generally have enough insulin, but it doesn't have its action. And there can be a variety of reasons why we don't have action of insulin. Many may have heard of the term insulin resistance, which is where your pancreas is trying to make more insulin to be able to meet the demands, so that equation of insulin and glucose and being able to use that glucose for energy. But I think in summary, type 1 diabetes is where we don't have enough insulin. Type 2 is we generally have plenty, but we're not able to use that appropriately because of resistance. And I'll mention that frequently in type 2 diabetes, we have to prescribe insulin because we will get a progressive defect in the way that the pancreas manufactures insulin. So it's critical to do the best we can to treat the hyperglycemia of diabetes so that we don't get progressive need for insulin. But as I said, it's not the end of the world if we have to take insulin, because we have very good ways to deliver these life-saving treatments to folks.
Thank you very much. Since we have people from different aspects of medicine here, I'm going to ask you guys to comment on how type 1 and type 2 differ for from your perspectives. Either one of you can chime in first.
Okay, I don't mind going first. So for me as a pharmacist, piggybacking on what Dr. Parker said, the difference for me really comes in when we treat diabetes. And because of the way that these diseases are a little bit different, and the insulin issue between the two determines how we treat. So as Dr. Parker said, with type 2 diabetes, it's more of the ability of your body to use the insulin that it already is making. So we use different medications to help make that insulin more effective, or make different parts of the body able to use that insulin more efficiently. Whereas in type 1 diabetes, it tends to be a little bit more of an issue of having that insulin production in the first place. So typically treat it from a pharmacy standpoint with giving exogenous insulin. So for me, that's the biggest difference from a pharmacy standpoint.
Thank you. Kevin?
Sure. Well, so from a nutrition standpoint, kind of a short answer would be that a diet for type 1 and type 2 diabetes isn't necessarily different. And a big reason for that is that there's not a magic bullet diet for diabetes. In both conditions, we would want to be aware of carbohydrate intake and how carbohydrates are affecting the body. As with Joshua, I mean, certainly diet is a big part of treatment of diabetes. The difference between type 1 and type 2 diabetes when it comes to nutrition is that diet can be something that can be used to prevent progression to type 2 diabetes, and not necessarily in type 1 diabetes. In a larger sense, the importance is healthful diet for everyone, awareness of carbohydrates for everyone when it comes to type 1 and type 2 diabetes.
Thank you very much. I would like to go back to Dr. Parker, and he talked a little bit about insulin in type 2 diabetes. Could you speak more about when patients will require insulin in type 2 diabetes, and just increase what you were saying earlier, please?
Certainly. Well, I think, through different means of monitoring the glucose, we will say we're at a point where perhaps we've exhausted some of the other avenues, which again, proper exercise will always help. And so we've gone through that. A lot of times we don't jump to injectable treatments in type 2 diabetes immediately. That has changed somewhat with the advent and availability of non-insulin injectables, which is something that I would just make sure that the understanding of it. And I think being able to fully explain this to folks so they understand why we would be doing our different interventions will be critical to enable them to not be resistant to these type of treatments. But in general, if they have exhausted other types of treatments, then we'll look at insulin, because sometimes the different medicines by their mechanisms, whether it's pills or primarily, pills to treat diabetes, oral agents, you must do this. Now, we might find it where, despite our best efforts, our fasting glucose, first thing in the morning, glucose will be elevated, or they're elevated after meals. And of course, that's when we're checking it by finger sticks and really nowadays continuous glucose sensors. But if you're just not at goal, and we of course look at our own monitoring, but also the laboratory monitoring that the doctors do. And so the number to keep in mind is the hemoglobin A1C. And just so folks will relate to that's a test that we can do every 3 to 4 months that will reflect on average where your glucose has been. And the importance of this is that we have from very rock solid science that we know where goals are to prevent certain complications in the setting of diabetes, and specifically problems with your eyes and your kidneys and nerves. Those are the ones that we know we can help. I would say, on the other hand, there are folks who have symptomatic diabetes, and the way to rescue them from that is to add some insulin. They may have frequent urination, thirst, fatigue, blurred vision types of symptoms, and insulin may be the only way that we can reach that end.
Okay, so you spoke about non-insulin injectables, and that was one of the most exciting things that has happened in a while for me. I loved it when Byetta came out. I remember that from, I don't remember, was it about 10 years ago? Or
no, it was 2005.
2005. Wow. Okay. All right.
Can I share something about Byetta? Byetta was amazing because it was truly a non-insulin injectable, and it changed the way that we approached things. And I think it helped so many patients. It was probably coincidental with the very small needles that we had too. We had these pen needles that were made, and it basically there was a different type of insulin resistance that existed, and it was patients being resistant to taking insulin and doctors being resistant to prescribing insulin. But it was 2005, and it was major. I agree, Doc.
That was major. Joshua, can you talk a little bit about what those non-insulin injectables, like how they work and what they do? Because often I tell my patients that I want them to take an injectable, and they just jump to insulin. It's really hard to explain that it's not insulin. So could you speak a little bit about that?
Absolutely, Dr. Jarrett, thank you. And I agree, these non-insulin injectables have been really great. So we have a few different ones. Like you mentioned, Byetta was one of the first ones that came out. But since then, we've made a few different leaps and bounds as far as administration with these injectables that are not insulin. So they're called GLP-1 agonists. There are a few different ones out right now. And for the most part, they're once weekly injections. Now, there is one that's a once daily injection, but they've been really good as far as the data has come out with them in a few different ways. First and foremost, the ability to lower that hemoglobin A1C that Dr. Parker talked about. Comparatively to all of the oral medications that we have, it's got one of the largest abilities to lower that A1C when you look at all the medications side by side. And also it comes with a little bit of weight loss with some of these injectables as well, which, as we can talk about, can play a role with our blood sugar control. So like I said, they're once weekly injections for the most part. They work in the body in a few different mechanisms. One of the main ones that we think about is that it slows our gastric emptying and it allows our body to help control those carbs that we're putting in our body as we eat. So in doing that, at first, some people can see a little bit of nausea, but it usually just takes a little bit of time for your body to get used to it. They've been really good for the most part as far as data is concerned in long-term protection from a cardiovascular standpoint, and that's really a benefit for patients with diabetes when we look at the progression of the type 2 diabetes long-term. As Dr. Parker mentioned, they do typically have a lot smaller needles, and they're very easy to use and administer. So I think they've been a really big game changer. And as we've kind of moved forward, we look at the original ones like Byetta, these newer ones that are out, so things like Ozempic or Trulicity, from an administration and a dexterity standpoint for patients, typically a little bit easier to use these newer ones as well. Did I miss anything as far as these GLP-1 agonists? Very good ones.
Thank you.
Yeah.
We talk about these GLP-1s. We got off into that, but I would like to talk about metformin too, because cost is an issue. Unfortunately, I don't know when the GLP-1s are going to get to be more affordable, but people come in and they have preconceived notions about metformin, which I think is a great medicine that's been around for years. It's kind of the beginning of treatment for type 2 diabetes. So can you talk about metformin also, Joshua, and how it behaves?
Yes, absolutely. So metformin is one of those, it's a staple drug of diabetes. For a long time, it's been that medication that has had some of the best outcomes and best data associated with it. We typically will use metformin in patients with prediabetes as well as with type 2 diabetes. Metformin works in our livers and it helps in a few different ways. One of the main ways is it reduces the liver's ability to produce more sugar when it's not needed unnecessarily. It helps your body to use the insulin that it has a little bit more efficiently, becomes a little bit more sensitive to insulin. And it's a pretty safe drug when we look at from the adverse effects standpoint. And like you did mention, cost is a very big issue with all medications in general. And metformin's been out for a while. It's generic, and it's typically one on the lower side of cost for most insurance plans, and even without insurance when we look at some of those copay cards that you can use. So very affordable, and it has some pretty good data as far as blood sugar lowering or hemoglobin A1C lowering as well.
Dr. Parker, would you like to say anything else about metformin, or did that cover it?
Definitely, I concur with Joshua there and you. It's a bedrock medicine, and I think that it is over the years been kind of a puzzling thing to me when my patients tell me that they read that it's bad for you, or I don't know the genesis of that information. And so I always just kind of stop and explain it to folks, because I'll hear, oh, well, it kills your kidneys. Well, it actually doesn't. And it's one of those things where it's like rumor is part true and part false, and you don't know which is which. And so I try to really explain it that certainly there can be some concerns with kidney disease, but it won't cause kidney disease. In fact, it seems to have some protective effect. So, but if you have a careful, medical team, doctor taking care of you, we're not going to let that get out of hand. We're going to make sure that you're safe for taking the medicine. And indeed, I think it was 2015 or 2016, the FDA even was more permissive with who they would allow to take it. And so people with some kidney dysfunction can do that. I do find that I have to, so I like to allay people's fears on that. I also spend a good bit of time talking about the best way to tolerate metformin too, because it's, you know, it's not unusual that it might cause some abdominal bloating or loose stools, so sort of gastrointestinal problems. So I always talk about taking it with the largest meal. If we can get extended release versions, that's often preferred. And it is, because it's so inexpensive, it's really a great thing.
I totally agree. It's a great medication. Kevin, let's talk about lifestyle changes with type 2 diabetes. Can you cure diabetes with lifestyle changes?
Well, if one has had a diagnosis of diabetes, then it doesn't go away. However, we will talk about diet-controlled diabetes. That being said, I do want to kind of echo some of what Dr. Parker and Joshua were talking about as well. If a patient needs medication, if their doctor has really recommended that medication, that's definitely a great thing to do and work on those lifestyle factors. So when it comes to diet, eating in a balanced way, so eating carbohydrates, but eating those carbohydrates with protein, with what we call non-starchy veggies. So there's things like, leafy greens and tomatoes and onions and broccoli and things like that. That's a very important factor when it comes to eating well. Also, we've mentioned that we have a lot of ways to check our blood sugar these days. And that's a pretty critical part of knowing how your body responds to the meals that you are eating so that you can make adjustments if needed. So if you are eating a particular way and you were to come to a dietitian like myself, one of the things that we would definitely want to know is kind of, well, what happens to your blood sugar a couple of hours after you eat that meal? Maybe not immediately afterward, because our blood sugar is always going to rise after we eat meals, especially with carbohydrates. And that's supposed to happen. But our blood sugar is also supposed to come back down reasonably so that we can keep that A1C in a good range. Beyond diet as well, though, getting regular exercise that's safe, also trying to manage our stress and protect our sleep. These are critical factors when it comes to keeping our blood sugar within range, because stress can increase our blood sugar. A lack of sleep can increase our blood sugar. And so even if we are doing very well with taking our medications and eating balanced meals, if we're kind of unbalanced in those other places as well, we may not get our blood sugar into range as we would like.
Thank you very much. Dr. Parker, do you have, can you think of a patient who has lowered their A1C significantly with lifestyle changes, or a number that you've seen with just lifestyle changes? Oh,
yes, ma'am. I actually have many times. And so I think you though have to know where you are in the in sort of the evolution of diabetes. So I had a patient who hemoglobin A1C of 12.5%. And so just to put it in perspective, the American Diabetes Association goal is less than 7%. A normal hemoglobin A1C for someone who doesn't have diabetes is probably less than 5.7, 5.6. So you can kind of look at it that way. And really, I didn't find that she had any other precipitating factors. Sometimes folks will have steroids for other reasons, prednisone and such, or they'll have other medical illness, which will really raise their glucose. But this is type 2 diabetes. And we had her enrolled in a program we did have at Wilmington Health called HMR, which is basically a way to have a medically supervised weight loss program. And in essence, she was able to eat reasonable meals, and it was calorie controlled, and the exercise measures for someone who had not been exercising may have seemed drastic, but it was simply 150 minutes of exercise per week. And she had obesity, and she was able to, in 13 weeks, she was able to lose over 5% of her body weight, and her A1C went down to 6.5%. So it was a drastic change. And so it probably was going to, and it did keep going down lower. So I've seen remissions. I've seen the other side of it. I mean, I have a patient currently who really is in complete denial and won't even take medications and checks her A1C frequently. In fact, pays for it, you know, herself instead of having us do it. And so there's a sort of bit of a psychological disconnect. I mean, my approach is to motivate people. So I have certainly tried my best to do this, but you do reach a limit. And so that's why having team approach with diabetes with our colleagues in the office and elsewhere helps out. But yes, I've definitely seen it happen, and but you have to catch it at the right point. I will also say that I have seen folks who are already on medications for diabetes, and they were able to make significant inroads and reduce medications through lifestyle modifications with diet and exercise. I think the one thing that can be a bit deceiving, and I you know, as of the first patient I told you about, we were rejoicing that she had done so well, but she needed to be aware that she had the condition of diabetes, and while it's in great glycemic shape, we had to make sure that the other accoutrements, that like cardiovascular disease risk and some other, you know, mostly cardiovascular disease risk were still present, and that should be her motivation to keep up the good work.
Right. One more thing, could you also speak to gastric bypass and how it affects diabetes?
Yes, so bariatric surgery can induce a remission of type 2 diabetes, and I think that in the case of obesity, when we have really gone through everything that we can do, and we really are doing it. I mean, when we are trying to get serious about what the diet is, what the exercise is, even quantitating it in terms of understanding how many calories we have in, how many physical activity calories we're burning, you can kind of get a feel for what one's metabolism is. And if, you know, I think about it in terms of a pin here, I don't see the best way to show that. Like, if you take in fewer calories and you increase your physical activity, that's the way to get the weight to go down. Well, some people just do that and the weight goes down, and some people have to do that. I mean, they almost go straight up and down. And so in those cases, I mean, there are pharmacologic treatments can help, like Josh was saying, but gastric bypass will work, and you can induce a remission of type 2 diabetes. But again, knowing that is also something that's going to require lifelong monitoring.
Thank you again. Kevin, can you tell us what a healthy diet looks like in type 2 diabetes?
Well, kind of broadly, I can, yes. Again, because everybody is going to react differently. However, so I mentioned those non-starchy veggies, and actually for anybody who has internet access as well, diabetes.org is the American Diabetes website, American Diabetes Association website. They have some really good information. And one of the things that they will talk about, and of course I will talk about with my clients as well, is that if we get about half of our meal at any given time to be those non-starchy vegetables that I was mentioning earlier, that's a good start. So I want to give a little bit more information about non-starchy vegetables and kind of our description there, because there are some plant foods, some vegetables that have more starches and thus more carbohydrates. So these are things like beans and peas, potatoes, corn, sweet potatoes, pumpkin. These foods are not evil. They're not bad. They have very good nutrients for us. And they are things that contain more carbohydrates and thus will push our blood sugar up more. By eating a lot of those non-starchy vegetables that don't have as many carbohydrates and having a reasonable portion size of a lot of our our carbohydrate foods. So be it those starchy vegetables, be it fruit, be it even some of our grains, and we would want to be aiming for whole grains as well. Keeping that portion size reasonable is something that helps keep blood sugar in control. And we also want to be consuming protein, though the amount of protein that different people need can differ, especially if they have any kidney concerns or anything like that. But the combination of protein, of some healthy fats, and those non-starchy vegetables that contain things like fiber and lots of nutrients can make it to where the carbohydrates that we eat in a reasonable portion will not cause our blood sugar to elevate sky high. It can help you really manage that blood sugar in a better way.
Thank you. So one of the questions that someone submitted was, if I feel fine, do I still need to worry about my diabetes condition?
I can speak to that from a medication standpoint. That's a really good question. I think it's a question that we've probably all seen to some extent in our careers. From a medication standpoint, I would say you still need to continue with your current medication regimen as pertaining to diabetes, even if you, from your own standpoint, feel fine. Even in settings where your blood sugar, that hemoglobin A1C would be below that 7 range or that controlled range, because we want to make sure that we keep our blood sugar controlled and stay at a good level. So sometimes we're not quite able to feel our blood pressure, or sorry, our blood sugar be too high, or even at the same time too low. So we want to make sure that we still continue to take the right precautions, take the right steps, especially with medications, to help continue to manage our blood sugar.
What are symptoms of type 2 diabetes? Anyone?
Well, you certainly can have frequent urination, thirst, blurred vision, polyphagia, which is an increased hunger. I mean, it sounds kind of paradoxical, but when there's plenty of sugar in your blood, you actually stimulates hunger. And you can have blurred vision, weight loss, you can have numbness or tingling in your hands and feet. And so those are, what we call metabolic symptoms. It's basically sugar toxicity, glucose toxicity. I think the part that's deceiving is you can have none at all. So it can be completely asymptomatic. And then that gets back to the idea of I feel fine. Do I need to worry about diabetes? And so I think, again, to echo what Josh is saying, you need to be concerned to have an awareness. I mean, people do, if you're talking about the drug treated patient, then it is worth consideration that you do feel fine because of your medications and not in spite of your medications. And so, but I think that, again, realizing that diabetes is really one face of a condition. And so understanding that you have a higher cardiovascular disease risk, and that as we were talking before about the hemoglobin A1C and the goals on hemoglobin A1C, like basically how sugared you are, how much your average glucose is, ties into microvascular complications, which is the kidneys and the eyes and the nerves, but not as much to macrovascular, which is heart disease, stroke, peripheral vascular disease, these type of conditions. So I think that you have to have the awareness that there are these associations, and with that goes along the idea of what you do to help treat those. I mean, thankfully, there's a lot of overlap in terms of diet and exercise and stress management and sleep and just, keeping calm. And, there's just like all these things when we were talking about, cortisol earlier, but also realizing that there is ample evidence of certain medications that will help out to prevent cardiovascular disease, and knowing what the cholesterol is and how you treat that. But then it gets into a whole lot of, well, this is a bunch of medicines. How can I manage this? That's why I think that when I communicate with patients, I want to make sure they're getting something out of it. I want to make sure that they understand the conviction that we're doing this for a reason, and we're not going to go out on a limb on some things. We're going to say this is rock solid data. This is rock solid information that we can help your kidneys with this, or we can prevent you from having a heart attack with that.
Since type 2 diabetes is not treated with insulin as much, sometimes, of course, it is. How often do type 2 diabetics have to check their blood sugars? And what do you recommend for them in terms of checking their blood sugars generally?
Well, I think if we're talking in the non-insulin treated population, it's right. We in the past kind of were, I don't know, I guess when we didn't have as good medicines, we used to check the sugar a lot more. I mean, the old Wilford Brimley, check your sugar and check it often kind of monolith was in our brains. But I think that what I tell is we need to get something out of this. You need to learn something from doing a monitoring. And so whether it's fasting to sort of indicate, well, what has the liver been doing overnight with my glucose? 2 hours after meal, 2 hour postprandial is what we call it. Those are very helpful in terms of monitoring, because you can at that point in time say, well, wait a minute, my sugar is 200 after I ate this meal. What was it? You can just police it at that point and say, well, what was it that was in the meal? Or you can certainly, congratulate yourself. If it's 140 2 hours after, you can say, well, that's probably something I can have again. And you just kind of put it into factor. So I would say that, with test strips being about $1 a piece, you kind of want to get something out of it. And I think that, again, as Kevin was saying, the continuous glucose sensors can be great. And I think there's pathways forward in a lot of folks, folks who are on insulin specifically, to be able to get, these will be attainable. They will be a much more commonplace even in those with diet treated or pill treated diabetes, but this just takes time for the rest of the insurers and to get hip to this.
So if I have type 2 diabetes and I check my blood sugar and it's 350 and I'm on oral medications, what do I do?
Well, that's the time to communicate with the healthcare provider, because something here is amiss. And I think it's not necessarily an emergency then and there, but if someone were, they had not had symptoms of hyperglycemia like we were talking about before, the frequent urination and blurred vision and thirst, and they were feeling unwell, then that's a reason to get a more immediate medical evaluation. But I think that if you have the diagnosis of diabetes type 2, you're being treated with a medication, and you realize that your glucose is say 300 after a meal, that is definitely the time to get reflective about what you've eaten, and also to communicate with the physician, because even if let's say it was what you felt was a reasonable meal, and it was that, then there's a mismatch between the type of medicine you're taking and your state of diabetes, as it were.
Thank you. So let's look at some of the other questions that we have. We've covered a lot today. I think we've covered all of the questions about type 2 diabetes. So does anyone have anything else to add? And then we're going to talk a little bit about type 1 diabetes.
Well, I think that I wanted to echo a little bit some of the things that we were talking about earlier. And you had asked me if diabetes can be cured, and we've spoken about diabetes being in remission. And I think that speaks to the idea that diabetes is a chronic condition. And sometimes that can feel overwhelming, certainly. And yet, when you have motivation, when you have a good healthcare team, we do know a lot of things that can really, really help. It is definitely a condition in which you need to know about your body, but with healthful diet that absolutely can be enjoyable, with exercise that can be manageable, and with taking medications regularly, it's the sort of thing that hopefully we're not going to see those complications. And that's definitely one of the big things that from a lifestyle factor sort of perspective, we're trying to work against.
Okay. Actually, I did remember, I also wanted to talk about long-term complications of diabetes. And I think Dr. Parker mentioned a few, but can you talk a little bit more about like dialysis and blindness, amputations, and why people have those type of complications with diabetes?
Yes, and we hope to avoid those, and those, so the microvascular, the ones that relate to problems with the nerves, kidneys, and eyes. So the nerve issues, so peripheral neuropathy is typically what can happen if we've got manifestations. So that can be painful. It can, if you have severe peripheral neuropathy, you can get muscle wasting. You get such a dense neuropathy in some cases that you injure your feet and you're not able to recognize that, and you kind of have a progression, but you have effects on the blood vessels, you can have infection. And so that's where we get, amputation. I think that having, looking at having us as doctors and healthcare providers, looking at patients' feet and making sure that we don't see significant problems that would require special diabetes shoes, which certainly in the Medicare patient set they're entitled to that. This is something that's been fought for in the past, and I'm a firm believer in it. I think that being able to lean on our colleagues in podiatry, foot and ankle, to be able to help folks to save limbs. But I don't think I don't see as much of that as I used to even 15 years ago. So this is progress, but definitely making sure that we're, from the nerve standpoint. There can be some other neuropathies. I mean, it can affect the lining of the nerves that control the stomach, and you can have this condition called gastroparesis, and that can create problems with meal selection, with blood glucose variability, with medication selection. I mean, you kind of write off a good class that we were talking about, these GLP-1 analogs. And so it does get to be a problem, and that's a bothersome issue for folks. I think from the eye standpoint, it's primarily retinopathy. So that the blood vessels that are feeding the back of the eye to keep that healthy, you can have a problem where they proliferate, that you have too many of them, and they basically kind of can burst. And that will take away sort of screen time, as it were, so that you don't have good vision. And that really can be limiting. And as we all know, we want to have all our senses. And when we don't have enough vision, or again, aside on that, our hearing is not good. I mean, that limits our lives, and we can become really sad and despondent. So we want people to be as connected as they can. We want them to get through their life. So that's, through improving the hemoglobin A1C, through having our colleagues in ophthalmology, make sure that folks who have diabetes need to at least annually have a look at their retina by an eye specialist. There have been different ways to try to put this a little closer to the people, and there are some issues with achieving that, but there are technologies where you just look into this camera and it takes a snapshot of the back of your eyes, and it'll know with artificial intelligence, do you have diabetes retinopathy or not? And at that point, we can say, yes, we need to get you over to an eye specialist. But, there's been some difficulties in deploying that, just from logistical standpoints. So, and then I think that, from a kidney standpoint, the effects that we can have on diabetes, and you can have problems with how it's mostly known as something called proteinuria, where you have an abnormal amount of your protein, which seems to leak through unhealthy kidneys. And if we have a progressive loss of kidney function, dialysis is necessary to really clean your blood and keep you from having toxicity. Fortunately, controlling diabetes and getting the average blood sugar down the A1C lower can curb that. There are very good medications, ones that are called ACE inhibitors or angiotensin receptor blockers that we prescribe. And as of the last few years, we've learned that some medicines which were initially approved as diabetes agents are actually better at protecting our heart and our kidneys. And just to name them, they're what are called SGLT2 inhibitors, and they folks may have heard of Invokana or Farxiga or Jardiance, but what these medicines do is they send more glucose out through the kidneys, but in a poorly understood way. Even after a lot of inquiry and examination, it seems to improve the vasculature, so the blood vessels. So I think that, and part of the issue with deploying these medications it's manifold. It's number one, making sure that the doctors and healthcare providers really understand the importance of this and the mechanism and sort of how this works. So to recognize it, if you go from saying, well, this was a sugar pill and now it's a save your life pill from heart attack and prevent dialysis, is a bit of a step. The other is there can be some side effects. Every medicine can have a side effect. And so we have to be able to counsel our patients properly and understand what to look out for. But I think most importantly is cost, because they are not cheap. And I think we have to come up with strategies. I will say, put in a plug for our group, Dr. Jarrett, with Wilmington Health, we have been blessed with a fantastic pharmacist who has been able to help assist patients who would not be able to afford medications. So I think that, and having the ability to use medicines to really get something out of it. As I said, I don't want you checking your blood sugar if we're not going to learn something from it. I don't want you taking a medicine if we're not going to benefit from it.
Absolutely, absolutely. Josh, I was just about to ask you about SGLT2s. As a matter of fact, I think they also help a little bit with heart failure. One of my favorite things about medications is how they can help with other things. So, and metformin has some other uses as well. And the GLP-1s, I think some of them are actually marketed for weight loss. So could you talk a little bit about those medicines and some of the other indications for them?
Absolutely. So let's start with the GLP-1s, like you mentioned. So these are these typically once weekly injectable non-insulin medications that we originally talked about. A couple of them do have dual indications for weight loss. They're manufactured and presented in a different form, a different name, but they are the same medication for weight loss. So Ozempic kind of doubles as a drug called Wegovy, used for weight loss. And then Victoza doubles as a drug called Saxenda, same idea for weight loss. Dr. Parker mentioned the SGLT2 inhibitors, the Invocanas, Farxigas, and Jardiance. Farxiga also has dual indications for protection in chronic kidney disease and as well as heart failure, whereas Jardiance also has indications for heart failure. And I don't think there's an FDA indication for chronic kidney disease specifically, but from the class effect, we tend to think that it does provide some renal benefit as well. Those are the main ones that we're seeing now that come with different health benefits, but with other indications. But if we go back to the GLP-1 agonists, they don't have any other specific indication for cardiovascular prevention. But through the data that we've kind of talked about, we've seen that there is some long-term prevention. We're not exactly sure how specifically, but from a cardiovascular standpoint, there is some protection there as well. Those are the main ones that we kind of see with dual indications and with other benefits, specifically for diabetes meds.
Okay, thank you. And then I was just going to add that metformin also has an indication for PCOS, which is polycystic ovarian syndrome. So I try to use real words instead of abbreviations. So, So we were going to circle back and talk about type 1 diabetes. We had a lot of fascinating information last month. We were talking about the continuous glucose monitors and how they work with the insulin pumps. So I don't know which one of you would like to talk about that a little bit and how this new technology has changed people's lives who have type 1 diabetes.
I'll be glad to take a stab at that. So with type 1 diabetes, it really has made a tremendous improvement. And so the concept is that you have a continuous glucose sensor, which is placed in the what's called the interstitium. So it's not really the bloodstream, it's not really the capillary, it's kind of the tissue. But it is such a good it's a reliable indicator as to what is going on in the bloodstream that it can be used in order to modify the insulin infusion. So in insulin pumps, it is one type of insulin. As many folks who get to a pump, however, likely will have taken different types of insulins, one which is a long-lasting one we call basal insulin, and one which would be a quick-acting one, generally for meals or for correction of high glucose, and that would be a rapid-acting type of insulin. But there's just one type of insulin in there. It's kind of like the type of insulin that one would have in a normally functioning pancreas in someone who did not have diabetes. But basically the part that is unique is that the data, the information from the sensor is fed through basically a computer program, which enables the insulin to modify depending on what the glucose is. So if you consider it an autopilot or a way to work a little bit better than the standard injectables. One of the benefits right out of the gate is that it eliminates hypoglycemia, significant low blood sugar. And it also has been shown to improve the hemoglobin A1C in a significant fashion. The lifestyle benefits that people can benefit, in terms of quality of their care, it really will decrease the burden of their self-care for type 1 diabetes. And I will say that in general, it helps to be very fastidious if you're treating type 1 diabetes. It's good to be a detail-oriented person and to be very careful about taking care of yourself. So I will tell you that there's only 3 insulin pump systems that are available. There were many more in the past, but there's really only 3, and Medtronic, Tandem, and Omnipod by Insulet are really the only 3 that are available. Medtronic was the first to have an integrated system where you had a IBM Watson artificial intelligence technology that used their sensor to be able to help out. Again, just from my clinical experience, the drawback has been that the sensor itself is very hard to use. It requires calibration through finger stick glucose at least 4 to 6 times per day to make it work. The other systems will use something called a Dexcom G6, which is you do not have to calibrate that with finger sticks. So again, there's something liberating to be able to be away from doing finger sticks, but you're never away from it if the machine is warming up or you ever need to sort of settle a dispute. You might want to, someone living with type 1 diabetes always needs to have access to monitoring. So the latest so the Tandem X2 with its Control IQ technology was approved in February of 2020 and came through, and that one has been very helpful. A system called Omnipod 5, which is the tubeless insulin pump, was approved earlier this year, and I have had my first patients prescribed just over the past few weeks, and we're really getting to learn that one. One thing that's interesting about that system is that you have a pod of insulin that's attached to your skin, much like the continuous glucose sensor, but there's no tubing, and you actually the the control is through your cell phone. So you really have a great bit of lifestyle improvement. It has good ability to control the high blood sugar and prevent lows as well.
Would a type 2 diabetic ever need a pump?
Well, yes. In fact, I'll tell you, I found that the Omnipod system works quite well because it's not insulin pumps initially were considered for type 1 diabetes, and you get into the issues of your insurance wanting to not pay for these things, not to go along with what the doctor and the care team think is best for the patient. Omnipod really doesn't have those same kind of restrictions. And so I found that it is quite suitable. But again, who are the folks? There are folks who really may have so much insulin, their dose is so high that the kinetics, the ability of the insulin to perform will be better with a continuous application of insulin through the insulin pump.
So one more question. Do all diabetics need to take statins, and including type 1 diabetics?
Well,
I'm sorry, I should say cholesterol medications.
Cholesterol.
All diabetics need to take cholesterol medications.
Well, it does tie into what the cardiovascular risk is, and I would say that that we need to, the ADA has guidelines, and so it's somewhat age related. Let's just put it that way, because I think if you're living with type 1 or type 2 diabetes and you're a woman of reproductive age, if you don't have significant cardiovascular disease burden, you really should hold off on it. But I think that it's something that we do want to intervene with early. So most people, I guess in my practice, if they're not on a cholesterol lowering agent, specifically a statin type of medicine, which basically keeps the cholesterol in the liver so it can be used for other things, they have to have a really good reason. And we don't torture people, but like the really good reason is, I mean, they can have, it's true that you can have medication side effects, and maybe Joshua can talk about that. But, there are other folks that have had ineffectiveness of it. It just simply doesn't work for them.
Well, we're actually running out of time. And normally I ask everyone to give just a quick blurb that you would like to leave with the community about type 2 diabetes, something that they can just hold on to and take home and remember as they go about their day. Kevin, can you start, please?
Yeah, absolutely. Thank you. And thanks again for everyone who participated and joined us today. What I would say, especially about type 2 diabetes and type 1, frankly, is that there are definitely wonderful medications on the market. And as you and your doctor talk about them and your pharmacist, you should definitely, consider their advice, take those medications. And lifestyle factors, healthful diet, exercise is always going to be a good idea. If we're eating healthfully, if we're exercising properly, then side effects are usually positive. Endorphin production and feeling more energy and sleeping better and things like that. So always something that we want to be doing and can have, again, a huge impact on how our diabetes is managed.
Thank you very much. Joshua?
First, thank you for having me and giving me the opportunity to speak to everyone. I'd like to say, with diabetes as a whole, I think we are in a much better position than we were 10, 15 to 20 years ago. So I remember back hearing about diabetes when I was younger, before even school, thinking, that this is like a completely life-changing event. And it is, but with the different things that we have, what we know about diet and exercise, the medications that we have now, these CGM monitors that we have as well, it makes living with diabetes, whether it be type 1 or type 2, I would say more manageable and easier for patients as we move forward and as they go on with their life. So I don't want people to kind of be too afraid of that, having diabetes. Like, there's a lot of things that we have now that makes things easier to live with diabetes and then have a successful life as well.
Thank you very much. Dr. Parker?
Well, I think it's an opportunity to empower oneself, to be able to take take charge of your health. I think it's important to realize that that you're doing this for you, you're doing this for other people, your family, those who you love. I would say that just understanding the truth of the matter and to be able to enable yourself to be helped. And I mean, I've got this luxury that every patient I see can be a winner. You know, I mean, I don't have to, there's no winners or losers. I want them all to be winners. And I want to empower people to realize that they can definitely succeed. They can live a long, productive life thanks to the shoulders of giants that we stand upon, who have learned to, who have taught us how to treat folks.
Thank you. And the last thing I want to say is know your A1C. I think that type 2 diabetics should always know what their last A1C was, because if they're going to a new doctor, if they're in a car accident, if they're going to have surgery or anything, then other healthcare professionals need that information. So always know what your A1C is. Thank you all very much for tuning in. Thank you, wonderful panelists. And we hope that you join us again next month for Talk on Health.